Well, good morning, everyone, and welcome to our fourth Fasken seminar on issues in seniors' homes. It's a real pleasure to have a number of people in the room with us, and I know that you're going to stay and have lunch with us afterwards. That is the reward for attending in person. But for all of those who are joining us online, you are very welcome as well. We have a jam-packed program this morning, but I thought before we got into it, I would just spend a moment and recount some of the highlights of the past seniors housing webinars Fasken has held. The first one we held was in 2019, and it was following the release of the report on safety and security of residents by the Honorable Eileen Jalise. This was after the unfortunate numbers of murders that occurred in the long-term care homes, and one of our partners had worked on that commission. So that was our impetus to have a session on that. And I was looking over the agenda for that, and we spoke about that, but we also spoke about staffing woes, which of course is as relevant now as it was in 2019, as we'll be talking about. And we had other interesting topics like accommodating addiction in the workforce. And then we had another seminar in 2020, and that focused on the Long-Term Care COVID Commission, what to expect out of that commission. And one of the topics we had at that time, and just again, the amazing amount of change that we've seen in this sector over a few years, one of the topics was granny camps and a whole question about whether they should be permitted to be used in long-term care homes. And we're going to talk a little bit later about how prevalent they are now. So quite a difference in a few years. And then in 2021, we had one, and it was really, the road to learning lessons from the Long-Term Care Commission. And also the government was on a big incentive at that time to build new long-term care homes. 30,000 was the number of new beds that they had aspired to create at that time. So we spoke about some of the challenges and opportunities there. We'll talk in our last session about the great distance we still have to go in that. So I am Lynn Golding. I'm the co-chair of our health practice group, and Lori Turner, my fellow co-chair, is on the dais here with me. Our program today is going to start with a look at the headlines. And every time you open, well, that's what when you open your app for your media or open an old-fashioned newspaper, you will see headlines about healthcare. So our first session is going to talk about some of those headlines, particularly as they are relevant to those in the long-term care sector and the senior sector. There are almost as many labor decisions that are relevant to this sector as there are headlines. And so in our second session, we'll be hearing from Aaron Porter and Lenny Lajasovics about the latest in labor rulings that are relevant to our sector. Then we'll have a little break. We'll come back and we'll talk about substitute decision makers and privacy matters at Fasken. We get a lot of questions about those topics in the long-term care sector. If we get a lot of those questions, I know you get even more. So Heather Whiteside will speak to us about that. And then in our final session, we're going to have a panel discussion, which I think will be really interesting, featuring a woman who is the head of a family council at a long-term care home. Donna Duncan, who is the head of the Ontario Long-Term Care Association, and Farah Ishmael, who is with SE Health. I'm going to tell you more about these three really interesting women and their panel discussion on the current state of long-term care homes at that time. So let me just give you a few pieces of housekeeping. If you are online, you will see a question symbol on the bottom of your screen. If you have any questions that you'd like us to pose to the speakers, please just input them there. At the end of each session, assuming there's timing, we will pose the questions to the speakers. Then if we don't get to all of them, we'll follow up with you afterwards. You will, at the end of this session and the days that follow, receive a survey, and we'd really love your input as to what you liked about the seminar, what other topics you'd like us to cover, that sort of thing. And we'll also have the materials available for you at that time as well. So without any further ado, I will turn the microphone over now to my two partners, Sophie McRae and Lori Turner, who will speak to you about healthcare headlines.
Morning, everyone. Thank you for joining us in the room and online. So my name is Sophie McCrae. I'm a partner in the Health Law Group. And as Lynn mentioned, I'm joined by Lori Turner, another partner and co-leader of our Health Law Group. So although it now seems a few years in the past, particularly for those who deal with this legislation regularly, since our last seniors housing symposium, there has been new legislation or replacement of the legislation that governs long-term care in Ontario. And the new legislation was drafted following the Ontario Long-Term Care COVID-19 Commission report and the Auditor General's reports, and reflects the focus that the provincial government and public have had on seniors care, and particularly long-term care, in the past 5.5 years since the pandemic. So on April 11th, 2022, the Fixing Long-Term Care Act 2021 replaced the Long-Term Care Homes Act 2007 as the governing statute for long-term care homes in Ontario. And while many of the Commission's recommendations were pandemic and infectious disease specific, the Commission also made a number of recommendations more generally for the system and care provided in long-term care homes, many of which are reflected in the legislation, and also significant amendments to the regulation under the legislation that have been introduced since. And so under the long-term care home legislation, licenses are issued, renewed, revoked, or suspended. Standards with respect to residents' rights, care, and admission are prescribed. There's investigation and enforcement provisions, and in many cases, particularly with the regulation, very detailed requirements for long-term care homes in Ontario. So since the new act came into effect, as I mentioned, there have been significant changes to the regulations, as well as other amendments to the act that we'll touch on today. But some notable changes that were initially introduced with the switch from the previous legislation to the new legislation in 2002 included a provincial target of a minimum of 4 hours of direct care. So that would be care provided by personal support workers, registered nurses, or registered practical nurses per resident per day by March 31st, 2025. The Act also included interim targets for the years leading up to it for 2022, 2023, and 2024. And this is a provincial average, so it could mean that the 4-hour target is being exceeded in some homes or some regions, but not met in others, and the province could still be meeting the target. And the minister is required to report on this target, progress made, as well as plans to achieve it. And I'll touch on where we are in the target shortly. In addition, the new legislation expanded the Residents' Bill of Rights, which is included in legislation and had been included in the previous legislation. So included a right to be provided with care and services based on a palliative care philosophy. That concept has since been expanded in the regulation, and it is a reflection of one of the Commission's recommendations. The Act also included a right to ongoing and safe support by caregivers. And the Commission's recommendations included several recommendations with respect to caregivers, and caregivers were a focus of the news coverage during the pandemic with respect to their access to residents in long-term care. In addition, the new legislation included enhanced compliance and enforcement provisions, and that included doubling the fines under the legislation, introducing additional administrative monetary penalties, and also additional powers of supervision. So the minister could suspend and take over a long-term care home without actually revoking the license at that time. And of course, we did see a number of long-term care homes go under supervision or be taken under control during the pandemic. And as I'll discuss a little bit later on, there have more recently been amendments relating to fines, which are relevant to directors and officers of nonprofit homes who will now be subject to the same level of fines that a for-profit director or officer would be subject to. So, as Lynn mentioned, the panel will discuss sort of where we are today in the wake of the Commission's recommendations. However, as an update to one of the legislative changes in particular, and which has been covered significantly in the news this year, is the target with respect to direct care. So the target was, or the interim targets were achieved in years 1 and 2. However, in the 3rd and 4th year, as we approached that 4-hour target, the province has fallen slightly below that target. So the Ministry of Long-Term Care reported that the average direct hours of nursing and PSW care in long-term care homes across the province as of March 31st, 2025 was 3 hours and 49 minutes, so 11 minutes shy of the target. The province indicated that one of the main issues is staffing and also the increased number of homes, which has, of course, increased staffing issues as there's more homes and more beds. And they particularly highlighted rural and remote communities as a challenge. So as I mentioned, this is a provincial average, and it may be the case that in rural and remote areas, that's what's bringing down the target even below the 3 hours and 49 minutes that's currently being achieved if more populated areas have a higher staffing coverage and are meeting that 4 hours. So the target remains in place and will have to be reported on again next year. And the province has, over the past 5 years, introduced various initiatives with respect to funding for additional staffing of nurses, staffing and training of nurses and PSWs in long-term care. There is another target for allied healthcare providers, so social workers, physiotherapists, of 36 minutes a day, and that one is being reported as being exceeded. So another legislative change that has been covered in the news significantly for the past few years, and then particularly this year due to a court challenge to the legislation, has been the More Beds, Better Care Act, which is an amending statute referred to as Bill 7. So Bill 7 amended the Fixing Long-Term Care Act and the Healthcare Consent Act to facilitate the transition of patients who were determined by a clinician to require an alternative level of care, referred to as ALC, from public hospitals to long-term care homes. So the amendments permit placement coordinators and long-term care home operators to admit individuals to long-term care without their informed consent. And the stated intention is to preserve hospital capacity as that part of our healthcare system is also strained, and ensure that care is being provided in the correct place as determined by a clinician. So the long-term care home amendments expanded the role of placement coordinators who can take various actions in respect of someone who has been determined to be an ALC patient without their consent or the consent of their substitute decision maker, provided that reasonable efforts have been taken to obtain their consent. So the placement coordinators can determine the patient's eligibility for admission to a long-term care home. They can select a long-term care home or homes for that patient. They can provide the home with assessments and other information about the patient, including their personal health information, and they can authorize the patient's admission to the long-term care home. If the patient or their substitute decision maker refuses to submit an application for admission to a home, the placement coordinator will make a selection of a home for the patient and submit the application. In addition to the amendments to the long-term care legislation and the Healthcare Consent Act, the Hospital Management Regulation under the Public Hospitals Act was amended to support the implementation of Bill 7 by providing that a discharged patient who remains in hospital for more than 24 hours after a discharge order is subject to a fee of $400 for every day that they remain in the hospital after that 24-hour period. So while a patient will not be physically removed from a hospital, if they refuse admission to a long-term care home, they would then become subject to the $400 daily fee. So Bill 7 was the subject of a constitutional challenge. The challenge began in 2023 and has been the source of both media coverage and debate among healthcare providers, as well as patient and public advocacy groups. So on January 20th, 2025, the Ontario Superior Court released its decision. So the applicants had argued that Bill 7 contravenes Section 7 of the Charter because they argued it limits ALC patients' rights to life, liberty, and security of the person, and that those limits are not in accordance with the principles of fundamental justice. They also argued that it violates Section 15 of the Charter on the basis that it discriminates against patients designated as ALC based on age and disability. The Ontario Superior Court dismissed the decision, and the applicants decided not to appeal. The court held that Bill 7 does not violate the right to life because Section 7 of the Constitution does not confer a right to a certain level of funding or health or social benefits. The court noted that no one has a statutory or common law right to occupy a hospital bed, particularly where a clinician has determined that a patient does not require the intensity of resources or services of a hospital care setting. The court also held that Bill 7 does not limit a patient's right to liberty or security of the person because it does not impose fines or imprisonment, and it does not compel a patient to do or refrain from doing something. and it doesn't authorize someone to physically transfer them, again, because it's the fee, the $400 a day that's applied, as opposed to more coercive mechanisms. With respect to Section 15, which protects individuals from discrimination under the law on the basis of various grounds, including age or mental or physical disability, the court found that the applicant had not proven that Bill 7 created or contributed to a disproportionate impact. And so the $400 fee would apply to anyone who refuses to leave the hospital after a discharge. The decision gave the example of a woman who's had a C-section and wants to remain in the hospital after the point where a clinician has discharged her. And the court also noted that any person, regardless of age or ability, who has been designated as ALC for rehabilitation would be required to depart the hospital if they're being offered a bed in a rehabilitation center. And the court was of the view that Bill 7 helps to achieve an important social objective of conserving healthcare resources and making hospital beds available faster, and that would significantly outweigh the alleged interference with someone's constitutional rights. And interestingly, the court reiterated what prior cases have found is that there's no statutory or common law right to be admitted or remain admitted in a hospital unless the clinician is of the professional opinion that being in the hospital is clinically necessary. So in sort of more ongoing or recent news, on May 8th, 2025, the Support for Seniors and Caregivers Act was introduced and passed first reading, referred to as Bill 14, seeking to amend the long-term care home legislation and the Retirement Homes Act. And this bill is actually being reintroduced after it was initially introduced before the provincial election. It was also put on hold again for the summer break, so is currently still at first reading. And it would require licensees of long-term care homes to have organized programs respecting dementia care and services for the home to meet the care needs of residents and with dementia. So one of the commission recommendations had been that long-term care home legislation be amended to ensure that residents' more complex needs are explicitly recognized and met. It would also require licensees of long-term care homes to ensure that there's an organized program to recognize and respect cultural, linguistic, religious, and spiritual needs of residents, including ensuring that residents are given an opportunity to practice their religious and spiritual beliefs and observe the requirements of those beliefs. And similarly, respect for and support of residents' cultural, religious, and lifestyle choices in long-term care services was a recommendation that the commission had made. Bill 14 also introduces 3 changes to the Fixing Long-Term Care Act that are particularly relevant to those who are working in governing over and operating long-term care homes. So Bill 14 would add new offenses to the Fixing Long-Term Care Act, providing that a licensee or manager of a home, a staff member, a volunteer, or a professional services provider is guilty of an offense if they abuse or neglect a resident of a long-term care home. Abuse is defined in the legislation and regulations, but the Ontario Hospital Association has raised concerns that the concept of neglect is not currently sufficiently defined. Bill 14 also amends the Fixing Long-Term Care Act to remove the differential penalties for not-for-profit directors and officers, as I had mentioned at the beginning. So this means that a not-for-profit long-term care home director officer who's found guilty of an offense would face the same penalties as director and officers of a for-profit home. So currently, not-for-profit directors and officers are subject to possible penalties up to $4,000. Whereas the standard provisions which apply to directors and officers of for-profit homes and would apply to directors and officers of not-for-profit homes if the bill is passed are $200,000 for a first offense and $400,000 for a subsequent offense. Additionally, long-term care homes currently require a medical director under the Fixing Long-Term Care Act, and this role must be fulfilled by a physician. Bill 14 would amend this role to be referred to instead as a clinical director, and it would expand the qualifications to enable nurse practitioners to serve in that role in addition to physicians. And the government has described this change as enabling flexibility, and it has also reflected on the fact that this approach was used during the pandemic. The bill also, in addition to the Fixing Long-Term Care Act, amends the Retirement Homes Act to add a right to ongoing support from caregivers for residents' physical, mental, social, and emotional well-being and quality of life to the Residents' Bill of Rights in that legislation. And a similar, although not identical provision is included already in the Residents' Bill of Rights in the Fixing Long-Term Care Act. Although interesting, the right that's being added to the Retirement Homes Act does not include a right to assistance in contacting a caregiver, which is included in the equivalent right in the Fixing Long-Term Care Act.
Great, thank you so much. So I am going to speak first to changes to the laws that apply to medical assistance in dying, known as MAID. And it's likely that you will have seen headlines circulating last year when the federal government announced a further 3-year exclusion of mental illness from MAID. As a reminder, MAID first became legal in 2016 when Bill C-14 came into force. And it was at that time that the eligibility criteria and safeguards for providing MAID were established. So in terms of some important dates with respect to MAID, the eligibility criteria that were set for MAID in 2016 continued in force until 2021. And they were broader than they are now. So among the criteria were that an individual be 18 years of age or older, and that they also be entitled to receive publicly funded healthcare in the province. Those criteria continue to exist today, as does the eligibility criteria that a person has a grievous and irremediable medical condition. However, what changed in 2021 is that the previous eligibility criteria that had been in place for the last 5 years of natural death being reasonably foreseeable was removed. So the removal of that eligibility criteria opened the door to MAID for individuals whose sole underlying medical condition is mental illness. And when I say sole underlying medical condition being mental illness, it might be, of course, that they have other medical conditions, but with respect or in the context of MAID, the mental illness is the only medical condition that would give rise to the possibility or the eligibility for MAID. At the time of the amendment in 2021, the government introduced a temporary exclusion, however, from eligibility for individual whose sole underlying medical condition was mental illness, so that those individuals are not currently eligible for MAID. In 2022, the federal government sought an extension of the temporary suspension of eligibility for MAID. And as a result of that 2022 delay, the eligibility date for MAID for persons suffering with mental illness was further postponed until 2024. Then in 2024, the federal government introduced legislation to extend the exclusion for eligibility for a further 3 years until March 2027. So it is to be seen what will occur in 2027. The 2021 revisions to Canada's MAID legislation established a 2-track approach with respect to the procedural safeguards that apply to medical practitioners when administering MAID. So all of the conditions or procedural requirements are the same, except with respect to one thing that we're going to talk about in a little bit. And the track to be taken is contingent upon whether or not a person's natural death is reasonably foreseeable or not. So as noted, part of the legislation changes in 2021, amendments were made to the procedural requirements for MAID. And 2 changes occurred at that time. Number 1, the procedural requirements that apply where natural death is foreseeable were loosened. And also safeguards that apply where natural death is not foreseeable were introduced. And as you'll see, they're broader than those for foreseeable death. So as you'll see on the screen here, there are numerous differences between the procedural requirements that apply. So for example, in the case of death not being reasonable foreseeable, the eligibility assessment that must be taken by 2 independent medical practitioners, which is a physician or a nurse practitioner, must take at least 90 days. And that 90-day period does not apply to reasonably foreseeable death. However, there is the ability for that period to be shortened if the person is about to lose the capacity to make healthcare decisions, as long as both assessments have been completed. And one of the other distinctions that applies is that in the case of natural death not being reasonably foreseeable, if the two independent practitioners who confirm eligibility don't have experience with respect to the mental condition that's giving rise to MAID, they must confirm and verify eligibility with practitioners who do have that experience. And that requirement does not apply in the case of MAID for natural death, where natural death is reasonably foreseeable. So in terms of what's next for MAID, so the government cited the following as a basis for maintaining that exclusion for mental illness for an additional 3 years until 2027. So number one, they wanted to provide provinces and territories more time to prepare their healthcare systems for expanded eligibility. Second, they wanted to provide practitioners with more time to train and become familiar with laws applicable to MAID, where death is not reasonably foreseeable. And also to better understand and become familiar with guidelines and standards that apply where MAID is delivered in those circumstances. And then finally, they wanted to delay this to permit them to align with recommendations of the Special Joint Committee on MAID, which had not yet been introduced. So the law that postponed the exclusion in 2024 required a joint parliamentary committee to undertake a comprehensive review of the eligibility criteria for MAID for persons who are suffering solely from a mental illness. And that bill imposed a deadline of 2 years. So by February 29th, 2026, that committee has to provide its review. So at this time, we're waiting on the joint committee report. And we'll have to see whether or not, if any of the procedural requirements for MAID where natural death is not reasonably foreseeable will be amended in any way. So next to the movement to expand the scopes of practice for health professionals. So there's been a movement over the last few years, in particular to expand the scope of practice of certain health professionals. Most recently, last week, the Ontario government announced its proposal to expand the scope of practice for numerous healthcare professionals. So with respect to the objectives, so why the government is emphasizing or supporting expanded scopes of practice, the government has identified 4 main objectives. So first, to ease burdens on health professionals, in particular physicians, by permitting other professionals to engage in activities that have historically been restricted to physicians. Second, to divert patients from overburdened emergency rooms to other healthcare settings. Third, to expand the circumstances in which patients are able to obtain healthcare and thereby increasing access to care. So for example, pharmacists have been the focus of many of these changes, and the recent ability of pharmacists to prescribe drugs to treat various ailments assists with access to care issues. So this permits individuals to obtain treatment from their pharmacists locally within their immediate community. And then finally, of course, cost savings. So certain of these changes are intended to shift patients to care modalities that are less expensive for the province to deliver. So for example, by moving individuals, so with respect to the changes for the scope of practice for pharmacists, what that means is that instead of receiving care in an institutionalized setting where the province is paying out of its pocket using OHIP dollars, that shifts the cost to patients. So patients must pay privately to receive that care from pharmacists. continuing the focus on pharmacists. So currently pharmacists are able to prescribe for and treat 19 ailments. And last week, the provincial government announced steps to expand the scope for pharmacists to allow them to prescribe for an additional 14 ailments, and also to permit them to engage in point of care testing for issues such as strep throat. The expansion of pharmacist scope of practice in 2023 followed changes that permitted pharmacists to administer certain inhalations and injections, such as insulin and B12. And just a note in terms of the success of the expanded scope of practice for pharmacists, as part of its recent proposal to broaden the scope of practice for pharmacists, the ministry confirmed that since January 2023, Ontario pharmacists have treated more than 1 million patients, and that 99% of community pharmacies are engaging in the program or relying on the expanded scope of practice. So with respect to expanded scopes of practice for nurses, effective in January of last year, the scope of practice for registered nurses was brought in to permit them to prescribe and administer certain drugs, including drugs for smoking cessation. And then with respect to this year, there was updates to legislation in July that led to nurse practitioners having the ability to order additional diagnostic tests and to engage in additional procedures, including, for example, cardiac pacemaker therapy. There's some other procedures that are listed there as well. And as part of the same amendments that occurred in July of this year, they amended the circumstances in which nurse practitioners can issue a medical certificate of death. Now there's very limited circumstances in which nurse practitioners can certify deaths. And the amendments also introduced the ability for the first time of registered nurses to complete a medical certificate of death in prescribed circumstances. That's where death is expected, and also where numerous other conditions are met, including that the deceased had a documented medical diagnosis of a terminal disease that was made by a medical practitioner. So with respect to additional expanded scopes of practice, the proposed changes to the scopes of practice introduced by the Ontario government last week would also impact psychologists, optometrists, among others, including dental hygienists, chiropractors, and physiotherapists. So with respect to psychologists, if implemented, the changes would permit them to prescribe certain medications, including antidepressants. However, psychologists would only be able to engage in prescribing where they have undergone specialized training and education in psychopharmacology. And psychologists would also be given the authority to order and interpret certain diagnostic tests, including certain blood work. The changes would also grant optometrists the right to perform minor surgical procedures in their offices under local anesthetic, use laser therapy to manage cataracts and glaucoma, and order diagnostic tests, and then also independently treat conditions that they previously were not permitted to treat. And finally, the changes would grant several other regulated health professionals the ability to engage in ordering and performing certain diagnostic procedures. So the professionals affected include dental hygienists, denturists, speech language pathologists, chiropractors, and physiotherapists. So moving on to the National Dental and Pharmacare plans. So both of these plans stemmed from the supply and confidence agreement that was entered into between the Liberal government and the NDP in 2022. So the NDP's support of the Liberal government was contingent on the Liberals agreeing to certain priorities, including this National Dental and Pharmacare plan. So with respect to the Canadian Dental Care Plan, or the CDCP as it's now called, First, in 2022, the first national dental plan was introduced, and that has now been supplanted by the CDCP. And it had always been the case that the initial plan was only temporary in nature and would ultimately be replaced by a more permanent plan. The CDCP was introduced in 2024, and as with the previous plan, the program is aimed to reduce financial barriers for oral health. And it began covering eligible seniors on May 1st of last year. So just a note that the CDCP is not intended to be a replacement for existing dental benefits that are offered by private insurance, but it's to fill existing gaps in coverage that is provided by provincial and territorial plans. So with respect to eligibility for the CDCP, individuals are not permitted to participate in the plan unless if they have any dental insurance or coverage. So that includes any private insurance from an employer or any insurance obtained as a result of being a student, for example. Second, the applicant and their spouse or common law partner must have filed their tax returns in order to permit the government to confirm their income in order to determine whether or not they're eligible for the program. The adjusted net family income must be less than $90,000. And also, individual must be a Canadian resident for income tax purposes. So moving on to the Pharmacare Act. So the Pharmacare Act came into effect in October of 2024. And like the National Dental Care Program, as I mentioned, it stemmed from the supply and confidence agreement between the Liberals and the NDP in 2022, which was, by the way, terminated by the NDP last year. So the federal government currently requires provinces and territories to enter into bilateral agreements called Pharmacare agreements. But currently only 3 provinces, being BC, Manitoba, and PEI, and 1 territory, being the Yukon, have agreements in place. And Yukon's program won't be rolled out until 2026. However, with respect to the remaining provinces and territories, there's been a lack of commitment, particularly since Carney came into power, as to moving forward with signing the outstanding agreements with the other provinces and territories. However, finally, the Prime Minister committed earlier this month to signing the agreements with the remaining jurisdictions, but he wouldn't confirm that his government would expand the program to be a universal insurance program, as was an essential part of the Liberals' platform in 2019. So the first round of coverage is limited only to the cost of diabetes medication and birth control. And what specific diabetes medication and birth control is covered is the subject of the bilateral agreements with the provinces. So it can vary, or provinces and territories, so it can vary dependent on the patient's jurisdiction. And notably, unlike the National Dental Care Program, eligibility in the program does not depend on a person's income or private insurance status. And it also does not depend on age, which the National Dental Care Program also now does not depend on age. In terms of eligibility, the person must be a resident of a province or territory that has a Pharmacare agreement in place. So again, that's currently only 3 provinces and 1 territory. They have to be eligible for public health insurance in the province or territory and also have a valid prescription for a medication that's covered by the program. So just before we turn to questions, I just thought I'd mention if we had a few other moments to talk about a bill that's also been introduced, which is Bill 23, protecting seniors' rights in care homes. So that passed first reading in May of this year, but there hasn't been any progression since May of 2025, so it's not currently in force. And so among other things, it would amend Ontario's Residential Tenancies Act And so while the Residential Tenancies Act has broad application, the changes that are the subject of this bill are more narrow to apply only in respective care homes. And that includes retirement homes and other residential complexes that are occupied by persons for the purposes of receiving healthcare. However, that term care home and the Residential Tenancies Act more generally exempts certain entities, including long-term care homes. So currently, the Residential Tenancies Act requires landlords of care homes to enter into a written tenancy agreement. However, prior to doing so, they're also required to provide the prospective tenant with what's called a tenant information package that includes prescribed information. So some of the significant changes of Bill 23 are that it introduces a requirement that certain of that content from that tenant information package, which was provided to tenants by the landlord, be included within the tenancy agreement. And also the bill would require that the charges be the same for each resident. So the charges that are the charges for any care services and meals be the same for each province or for each resident. So there can't be inconsistency in the charges between residents. Also, that residents be given the option of choosing from receiving a package of services or services independently, so on a fee-for-service basis. And it also would impose an obligation on the landlord to reduce the amount that they charge the resident if either the quality or quantity of the care services or the meals are reduced. So the bill would also introduce additional restrictions on increases to charges for care. So it would prescribe a requirement, so a notice period, and also would a notice period that would apply. So changes to the charges could not be introduced until that notice period was up. And also it would impose limits on the number of changes or the frequency of changes. So charges could only be changed a maximum of once per year, and the charges could only increase by the set percentage.
Okay, well, thank you, Lori. So that bill is just at stage one, so it may or may not come to fruition. It could have a lot of amendments. Certainly a lot of work would have to be done to implement that. Any questions? We have time for one question. If there's any questions in the room for the panelists. All right. Well, Sophie and Lori, thank you very much. I don't need to read the newspaper today. We've gotten all the headlines now. Thank you. And we'll invite up our second panel. Okay.
This moves back. Okay.
Thank you. Well, we are very fortunate at Fasken to have a large labor and employment group. I think it's the largest firm team in the country. And it's certainly the largest in the healthcare space. And we have with us Aaron Porter and Letty Lasagisics. And they are unique not only for their great knowledge, but also their practical experience. So Aaron did spend a secondment, she took a secondment away from Fasken, a short stint away from Fasken, where she worked as a legal counsel at Rivera, so has in-depth experience, practical experience. And Lenny, before joining us here, worked at a hospital in Cornwall, where Lenny, I'm sure you dealt with a number of ALC and other issues involving our seniors. So today, Aaron and Lenny are going to speak to us about the latest in labor and employment cases, particularly labor, and how they may affect the seniors care sector. So over to the two of you.
So thank you. It's great to be here with you this morning. I'm Lenny Lassex with Aaron Porter as well. And as Lynn mentioned, I think we bring hopefully a practical experience and insights, not just from a legal perspective, but an on the ground perspective, knowing, the challenges many folks in attendance face. And so what we wanted to do for our 45-minute segment this morning is just talk about some key labor employment developments, trends. We're seeing some hot button topics, especially around, let's call it remote work, managing risks through employment agreements, which is always an ongoing issue for Ontario employers. Erin's going to talk about family status accommodation and what she's seeing. And then I'm going to end the update with some bargaining trends. Now, we know, some folks here are from unionized employers and others aren't, but we know in this space that collective bargaining has a big impact even on non-union employers because it sets the trends. And so just want to give you an update on where we're seeing things at as we sort of are midway through 2025, a little more than midway, in what's turned out to be a very interesting year and an interesting last 5 years. So let's kick it off with just some case law trends, what we're seeing in 2025 so far. So some 3 key areas. We're seeing a lot on return to work, remote work. All you have to do these days is turn on the news to see another announcement that another major employer has, saying we're bringing people back to work 3 days, 4 days, in some cases 5 days a week. We saw a big announcement from the Ontario government a few weeks ago about that. And of course, with these announcements comes challenges for employers, some of who embraced, remote work and went sort of a digital first strategy. Others in this space, of course, where patient care is being delivered may have never gone to fully remote work, or some employers have gone to hybrid models for some of their office staff compared to frontline staff. So we'll talk about that. Of course, one of these ongoing issues for anybody working in this space, termination clauses. So how do we manage risk in an environment that seems to be ever changing? And you can never really pin your finger on how do we make an enforceable termination clause in this day and age to manage risk? And just a brief DEI update in the law in terms of an interesting case involving a special program. So let me kick it off by talking about remote work. And I just want to talk about, this is a case, it doesn't involve accommodation, because Erin will talk just briefly about that. But what it does talk about is how does a labor arbitrator interpret a collective agreement entitlement that provides for remote work or telework, as it was sort of used to be called before the pandemic. So we forget before the pandemic that, telework, remote work did exist, not nearly as ubiquitous as it became with, employers scrambling for infrastructure in February and March of 2020, where, a lot of people can work remotely when they, infrastructure wasn't as great before. I remember before the pandemic, many employers had VPNs, but they had limits on the number of employees that could be connected at any given time. So there's all these challenges about it. So in this case, we actually had a collective agreement that provided for telework arrangements within the collective agreement. So not just, something fresh, but this is, pre-pandemic. And this is a small employer. And interestingly, the employer itself is actually a union. So many unions, for those of you who don't know, actually have a lot of unionized staff. So within the union, you have staff represented by unions. So in this case, the employer is QP.
Which is sweet
Yeah.
justice. Can we just say it is
Yeah.
sweet justice? Organized by a different union than themselves.
And it turns out there's a lot of grievances out of unions as employers, which is interesting. So this is 13 people in this little local that's represented by a union. And the griever in question here wanted to work from home 2 days per week. Employer says, no, thank you. You can't do that. Then in response to the employer denying that request, the employee says, well, what about if I can sort of work at remotely at home ad hoc, meaning like 1 day, every few weeks kind of thing, right? Not 2 days a week guaranteed, but, every now and again. The employer says, no, can't do that. So union grieves. And in this collective agreement, it created a right to telework with conditions. And so the arbitrator is assessing this and saying, well, look, this isn't just a random request and there's no language in the collective agreement in front of me. I'm tasked with interpreting this request in denial in light of actual language giving a right to telework. And so what the arbitrator said is that it must be considered in good faith. It must be determined on a case-by-case basis. and it must be reviewed on the nature of the work and feasibility to perform it off-site. And so this was actual language in the collective agreement. And I do think, though, why it's relevant to us is that there's going to be a lot of these cases. There already are a lot in the queue. And I think it will be very informative to how arbitrators are going to interpret these types of requests and denials, where there is language and where there isn't language. Now, what the arbitrator did after assessing this is said, look, the nature of this person's work is such that they can work remotely, and the employer just carte blanche denying it, given the language, that's not reasonable. And so the arbitrator granted 1 day a week to start to be reviewed. And anytime you talk to a lawyer, they're always going to say, well, it's case by case. And, in this case, that's what the arbitrator did too. And so I think what an employer does need to do is an analysis when they get these type of requests, especially if there's language. They need to look at the language, analyze the request in light of the language. And we know there's a lot of pressure from the business side of things to get people back in. So where you have existing language, I would say be very careful as a lesson learned, because an arbitrator is going to breathe life into the language if it does exist. And what you'll see, just as a preview in terms of my collective bargaining update, where there isn't language in any collective agreements, expect that at the bargaining table, if the unions haven't already proposed it, they will propose it because they want a toehold, right? Language in the collective agreement gives them a big toehold. So let me just scan through a few. Yeah.
And what about in cases where you don't have it, it's not for unionized employees, and we're just talking about employees who have been working from home? Historically, we would have said, oh, you can't work from home, everybody must be in the office. And then during the pandemic, we said, isn't it great how well we pivoted? And now people are able to successfully work from home. So what happens to those people if there's no language in a collective agreement that's sort of confining you?
That's a good question, because I think, the script on that is still to be written to some degree, because those cases are being litigated, will be litigated. But I would say that, if there's no language, right, in a collective agreement, employers have management rights to, impose rules, policies, terms and conditions where it doesn't exist in collective agreement, subject to acting reasonably. So I think what an employer would face in a situation like that, of course, it's very fact specific, but what an employer would face is, well, is it reasonable to say nobody can work remotely when we've allowed it throughout the pandemic, for example? And so you really have to do an analysis to say what's changed. Is there any basis to, completely deny remote work? And so I think you're really doing an operational analysis and how that feeds through. Of course, during the pandemic, there were public health directives saying employers, if people can work remotely, you have to let them, or you have to have them work remotely. And so I think you really need to look at your operations and have a really good rationale to bring people back in. A business reason, is there frontline care, for example? That's a pretty easy one. But we're gonna see these play out in the coming years, I think.
Thank you. I wanted to ask about performance management. Where does that come in from remote work?
It's a great question, because I think that's one of the big question marks I have on remote work. And I think that's a really good justification for an employer to bring somebody back into the office to say, look, during the pandemic, performance management became a lot harder. And I've had this conversation, and I've done COVID vaccination grievances where we were talking about remote work, where employers, have said, look, we were more lax during the pandemic because of these remote work situations. It was a public health crisis. But I think for an employee struggling, right, for mentorship, performance management, I think having them in the office where there's other people, the managers there, right, they can be mentored, buddied. That's a great justification.
I think too that particularly, well, I perhaps in both cases, but if you're looking at non-unionized employees as well, then it's important to have a policy in place.
Mhm.
And so that policy would set out that working from home is a privilege, and that you only get to work from home if other conditions are being met. And often one of those conditions is that you're at least meeting expectation on annual performance reviews, or you're not on a performance improvement plan. And so I think that you really want to lay your foundation and making sure that you have some sort of policy that's going to ensure that you're treating every single person the same, while at the same time looking at every case on a case-by-case basis, right? But at least you have a framework that would say, these are the expectations and conditions. But I'll leave you guessing and really, dying with anticipation, because I have a case later on where we talk about that problem that comes into play about what happens, and that's an accommodation case, but what happens when you have someone working remotely that you then put on a PIP. Stay tuned.
Sorry, we just have to get you on the microphone because otherwise people online can't hear.
Thank you. Thank you. For example, if employer requires like employees to come back on a full-time basis, but very many organizations, they made some changes that it's not sufficient office space or different other things. So in order to bring people back, they should have like normal conditions of work. So is it something that, should be somehow implemented internally before, like pushing employees to come back to normal schedule? Because this is the case in many different organizations, from healthcare, senior care to any, financial sector, whatever.
Yeah, so just in case people online can't hear, the question is, what if your workplace can no longer accommodate everyone coming back to work? And so that happened here at Fasken. We got rid of some floors during the pandemic, as lots of employers did, right? We did the same. And it was fine because people weren't coming in on a consistent basis. And so you moved to an office share or hoteling landscape. So obviously, if you're going to have everybody who comes back to work, you're going to need to make sure that you have places to put them. But just because someone had an office before doesn't mean that they necessarily get an office now, because you can move the model, right? You could say, okay, we used to have individual offices and now we have hoteling, or now we have bullpens, or now we have whatever, as long as they can't then turn it around into a constructive dismissal complaint, right? To say, well, I'm being targeted and how embarrassing that I, was a senior vice president and now I sit in a bullpen with, with low-level employees. So you would have to, again, demonstrate, well, it's not embarrassing because this applies all across the organization, or we've made accommodations to make sure that people who need to take phone calls and have privacy and space can do that in, in separate meeting rooms or things. So certainly, it's not as easy as just saying, come on back, because a lot of time the landscape in the workplace has changed. But it doesn't have to be exactly as it was when people left.
I would say, because I'm seeing this play out in many workplaces, if an employer has made changes to the working environment, like you've gone down offices and it's more open concept, or there's different, types of work, get your ducks in a row before bringing people back and increasing that, because expect that there will be accommodation requests on those basis. Certain people don't want to work in an open concept environment. There's, perhaps they have cognitive restriction limitations. So anticipate that you'll see accommodation requests around those types of issues. Excuse me. And so just to jump back in, shifting gears a little bit, just to scan through just some basic case law. These are some general principles that I think many in the room will have heard over the years, but we just wanted to take you through some of them briefly. One of these cases, it's out of BC, but it's a great reminder of the importance of offer letters and what's called fresh consideration. So in this case, somebody was hired, they were offered employment and sent an offer letter that they accepted. And then that same day, they're sent another employment agreement with additional terms, including a termination clause and a non-compete. They sign that back as well. They're then terminated a little while later. And then they claim that the termination clause is unenforceable because the second employment agreement they signed with the termination clause, there was no consideration. And the court agreed with that. So the good reminder here is, and it talks about in the next case too, is that where you're getting employees to sign employment agreements or amendments, you need fresh consideration, which is basically something in exchange for them signing that agreement. And in Ontario here, the amount of consideration is not necessarily that relevant. Although I would say, I think you got to try to be proportionate, right? If an employee is signing a new employment agreement and they're giving up existing entitlements that they otherwise would have had, you need to be relatively proportionate with the consideration. Like just giving somebody $1 in exchange for a termination clause, providing for minimum standards when they had common law notice and they've been there 20 years, that's arguably disproportionate. I see we have a question.
Yeah, so when you thinking about employees who've been with an organization for like 20, 30 years or more, and then the institution or the organization wants to update all those employment,
Yep.
you're talking about fresh consideration for all of those as well?
Absolutely. So if you've had an existing employee who's there for 20, 25 years, and many organizations, especially with the case law in Ontario, invalidating a lot of termination clauses, wants to do a template update. That employee who's been there 25 years probably doesn't have an enforceable termination clause any longer if they signed an agreement 25 years ago, if they even signed one. And so if you're imposing a new employment agreement that has a termination clause that's very, much more restrictive than their common law entitlements, you would need to give them fresh consideration. And so I would say if you're undertaking those kinds of projects, definitely reach out for advice, because you don't want to go down the road 3 years later thinking you have an enforceable termination clause, only get a wrongful dismissal action looking for 24 months notice. And the same is true from this Hungry Panda case. Employee started employment already, then gets an offer and agreement letter after they've started. Turns out that's not enforceable because there's no fresh consideration. They started employment already under what's called implied terms and conditions. So one of the lessons from the Hungry Panda case, besides being a really cool name of an employer, is the fact that you need to make sure that when you're hiring, the employee signs back the employment agreement offer letter before they commence employment. Because once they commence employment, if they then sign back the offer letter, they will already have been employed under the implied terms and conditions, and that likely won't be considered fresh consideration. So do not let that employee in your building or online until they've signed the offer letter back. A little bit of a weird case out of Ontario. You might have seen this one in the news about a year ago. This case basically found that if a termination clause said that the employer could terminate the employee at any time, it was going to be unenforceable under Ontario employment standards legislation because of the fact that theoretically, an employer terminating an employee at any time could then violate employment standards legislation. For example, if they were reprising against an employee, or if the employee was on a protected statutory leave and they were terminated, that would violate the employment standards, and therefore the clause was unenforceable. I think it's a pretty absurd interpretation, and so did many employers. Turns out that it was appealed to the Court of Appeal, but the Court of Appeal didn't actually touch the question of this at any time language, because they found the clause was unenforceable for other reasons. So where we're at just on this at any time language, if you have at any time in your termination clauses, I would say, it's worth reaching out and talking through it, because we've since seen in the last, 6 to 12 months, we've seen a couple of cases basically looking at this line of at any time case line, basically saying, no, that's absurd. We're not following that. So we've got a kind of fork in the road situation here at any time. But if you get a demand letter from employee counsel who you've terminated, they'll say, no, this is good law. You owe us common law notice. But so I would say tread carefully for now about this. This is another interesting case here around just what I'll call a restrictive covenant, like a quasi non-compete. So in this case, People Corporation, employees signed an employment agreement as part of a sale of business, and it contained a restrictive covenant saying that the individual cannot provide services to, cater to, or accept business from, or accept as a client all persons who are a member of the People Corporation group, and that was the employer. So they left the company and started a new competing business. Of course, employer doesn't like that. So they they seek injunctive relief to prevent them on the term of that restrictive covenant. The court looks at this, and I think this is important to highlight that it's an Alberta court, which traditionally tend to be more employer friendly than Ontario and some other provinces. And they said, you know what, that restrictive covenant is really just a dressed up non-compete clause. And that's not enforceable because it contains no geographic limitations, right? It's just across the world, basically. And so they found that's not enforceable. And I highlight this because, when we talk about non-competes in Ontario, they're very hard to enforce, very hard to enforce. And of course, I think it's about 3 years ago now in Ontario implemented law that said for anyone in a position below the C-suite level, you can't have a non-compete. So where we're at in Ontario today is non-competes, outside of the sale of business context, likely to be non-enforceable and in the regular employment context, you can only have them for executives. And so really focus on non-solicitation covenants when you're looking at employment agreements today. I'll just highlight this case is that in the context of fixed term employment agreements, if you don't have an enforceable early termination clause as an employer, you could be liable for the balance of the fixed term. So just to highlight this, if you employ somebody for a fixed term of 2 years and you terminate them 6 months in, if your termination clause, your early termination clause is not enforceable, the law says you could owe them to the balance of the fixed term, which being a year and a half, for example, in that situation, that's a lot of time. And I'll just move ahead quickly here. There is some hope that termination clauses are enforceable. In this case, a court found that a clause was enforceable in this data stealth case. And I won't get into the nuts and bolts of it, but I want to highlight the case that there is hope, right? It's not all doom and gloom, like there is hope. I think we're turning somewhat of a corner here around stability in termination language and risk management from employers' perspective. That's what we care about. And so we have some decent language now to go off and go forward. The last case I'll highlight before turning it over to Aaron, because I know I'm running late on time here, is just that special program language in human rights. So this case out of lo and behold, another union, Public Servants Alliance of Canada, they had a job posting for a position and they were looking for quote, a qualified woman. And the posting for the qualified woman for the position came out of an employment equity plan and a gender equity task force report. And so the Public Service Alliance said any new position or any new vacancy, we're going to undertake an analysis to see if it's caught by, our employment equity plan and gender equity task force report to see if it should be, for example, a female filling it, a qualified woman. And so that's what they did. And the analysis said, okay, this should be posted as a woman, as a special program. A man applied for it and then alleged he was being discriminated against because he was excluded from the position, obviously. Human Rights Tribunal hears the case and says, look, this was done in good faith and it falls under the Human Rights Code special programs exception that says, a right under the code is not infringed where the program's designed to relieve hardship or economic disadvantage or to assist disadvantaged person or groups to achieve an equal opportunity. And in this case, the special program test was made out because the employer had really done a lot of legwork through its employment equity and the task force, analyzing these positions to get there. This wasn't random, right? Where they said, okay, this posting, we want a woman only. And so special program language does exist and the tribunal will uphold it, but I would say an employer has to do their homework to lay the groundwork for it. So Aaron, we're running late, but I'll turn it over to you.
Great. Thanks. So can I just get a sense, how many people in here have responsibility or oversight over employees in their workplace? So only very few in the room, maybe some more online. The great thing about our area of law is that we have good stories, right? So if nothing else, we like to say we're not as dry and boring as perhaps some of the other legal areas. So maybe we can at least keep you interested with the stories that we have. So I'm going to be talking about family status, and under the Human Rights Code in all of the provinces, but I'll focus on in Ontario, there is a protection for against discrimination based on family status. And the code defines that as being in a parent and child relationship. And the parent and child, the employee could be either the parent or the child. So it both is involved in childcare and elder care responsibilities. And we will send out the slides, I believe, to people afterwards. So so you'll get all of these, the slides and the case references. So there was a very exciting debate for those of us interested in human rights legislation across the country about what the proper test for family status is. And different provinces and jurisdictions came up with different tests. Unfortunately, Ontario's test is not the test we probably would have preferred as employer counsel, but it's Missy Titch and Value Village Stores is the case that that came up with it. And what it says there is that the employee must establish more than a negative impact on their family, and it has to show a real disadvantage. So what that actually means is that it can't just be something that all parents would run into. So we can't say, well, I can't come to work, or I can only work from these hours, from this hour to this hour, because I have a child at home and I have childcare obligations. Well, that's the plight of every parent, right? That you are going to have childcare obligations that impact with the time, usually, that you have to be at work. So there has to be something unique about your circumstances that would sort of take you out of what just the normal obligations would be. And so the legal test was established. Are you in a parent-child relationship? Have you experienced adverse treatment at work? And is the fact that you're in a parent-child relationship a factor in the adverse treatment? So what does that mean? Well, let's see. And this will be great because if a lot of you don't have day-to-day experience, then this may be something where you're like, I don't know what we would do. So here's a scenario for you to think about. You've got a single parent who's in the process of working out a custody arrangement. They've asked to leave work at 3 on Wednesdays and every other Friday to pick up their kids from school. The regular hours are 8:30 to 4:30. So what do you do first? What's the first step of the test? Are they in a parent-child relationship? So yes, so here's a single parent. So first step of the test is met. Are they being adversely treated? So they have to leave at 3. Their hours of work are 8:30 to 4. So there's an adverse impact on them. Okay, and is that adverse impact a result of the fact that they're in a parent-child relationship? Yes, but now what do you think happens next? Do you think that that just means that, okay, they get to go because they have a custody arrangement? Maybe, because we love to give uncertainty in the law. So there are a number of cases in the past little while that have looked at custody arrangements in particular. And this is something I've had several hospital clients, for whatever reason, in the last year have come up and asked me about custody arrangements. And so this seems to be a hot topic right now. So I thought maybe you also would think that these are interesting. So here are 3 different cases that come to 3 different conclusions, which really helps clarify where the law is on this. So I thought I would share them with you. So the first one, Linklater. And so in this case, a father had a joint custody agreement that was determined on consent by the Superior Court. The custody agreement was built around the father's work schedule of 4 days on and 4 days off. And then the schedule at work changed. And so the father then said, well, I need to be accommodated. And the employer said, well, we can't accommodate you. You have to work this new schedule. And the tribunal said, that's right. And they also said that the employee, so the father, didn't bring forward his concerns about the custody agreement and what the impact of that would be, the new schedule would be on his ability to see his family or his children. And he also didn't come forward with concerns. He had suffered a workplace injury, and he didn't come forward with concerns about how that would also intersect with the new schedule. And so the tribunal said, onus not met here, but if the father had brought forward the concerns about the custody agreement and the impact that that would have, then the employer may have had to make alternate arrangements if it was able to do so. So first lesson from that is employees have to bring information forward. And if they do, then you have to consider it and go through the process. The second test is Saroyan. So here the applicant was transferred from a midnight shift to the afternoon shift because all of the midnight shifts were eliminated. So midnight shift no longer exists. He came forward and said that this interfered with his child access agreement. Again, it was an agreement certified by the court that he had access to his children. And so he said, I can't do the new afternoon shift because it interferes with my ability to pick up my children. And here the tribunal said, too bad. The employer gave you lots of notice to make other arrangements, and you are in no different a position than any other parent would be who has to work an afternoon shift. And there is no midnight shift anymore. So they couldn't accommodate you by keeping you on the shift because that shift is gone. And so the employer gave them ample time to try and find new arrangements and to try and put something else into place. And he did nothing to help himself and see if there were ways that he could make different arrangements. And so then the tribunal said, no, too bad. And you're like, okay, I think I'm getting it. I think I know now what has to happen. And now comes a decision, IBEW, and it is an arbitration decision from Norm Jessen. And in this case, again, the shift had changed under the collective agreement, and 4 different individuals brought forward complaints saying that they could now no longer meet their family obligations. 3 of them were still with their partner, and so 2-parent household. And in all 3 of those cases, the arbitrator said, too bad, you have to make other arrangements, trying to care for a child and make sure that they have proper daycare and you can get to their sports activities. That's part of every parent's life, right? So not treated any differently. The 4th one, though, did have a custody arrangement. Again, it was an agreement that was approved by the court. And so arbitrator Jessen in that case said that matters. So because you have this agreement, and he called it a well-crafted document that was developed in the best interest of parent and child, that had to be honored. So unlike the case before where they said, well, that's still, whether you're a single parent or a parent with a partner, it doesn't matter. In this case, they said, well, you're a single parent. So of course now it would be much more difficult for you. So that's all to say is that the case law still is a little bit uncertain, but we do have some takeaways and some things that we have learned. So custody agreements are viewed as carefully crafted agreements that try to provide the best for families. So you need to, if you have someone who comes forward and asks for accommodation, ask for the custody agreement, or if there is a custody agreement, and ask to see it. An employer has an obligation to consider whether it can accommodate the needs set out in the custody agreement. And this may mean offering alternate shifts if they're available. So you don't have to create the midnight shift if it's not there, but are there other options that are available? And then employees also have an obligation to participate in the process by considering whether the custody arrangement can be amended or if there are alternate childcare arrangements that can be made. All right, what would you do? You have an employee who's worked as a scheduler. Her hours are 8:30 to 4:30. She's often late. She's late, and you say some things to her, you bring it to her attention on occasion, but she's never really disciplined. She goes off and has a 3rd child. And while she's off, you give her a letter that says, hey, when you come back, you really need to start at 8:30 because you're a scheduler and you're scheduling, I think she's scheduling buses in this case. And so we actually need you to work between the hours when you have to schedule buses. So you can't just shift your day and work 10 to 5. We need you there 8:30 to 4 or to 4:30. And she asks for accommodation because she wants to be able to drop her 2 older kids off at the bus. So her infant is in full day daycare, but the 2 older kids, and the kids are in after school daycare, but she doesn't want to do before school daycare. She wants to be able to drop them off at the bus. Show of hands in this room, how many people do you think that she would have to be accommodated? So she would get to drop her kids off at bus. She doesn't have any daycare. How many people think that that's it? It depends. We've got it depends. What does it depend on? Okay. Okay, so I'll repeat it just in case people online can't hear. So the response was, if it doesn't impact the company, then the company should have to consider whether or not they would accommodate her. And I will say no. I will say that the company gets to, so first of all, in this case, it did impact the company because they needed her to be at her job so she could schedule during the hours that scheduling needed to happen. And second of all, even if it doesn't, the employer gets to set the hours, right? Like that's, the employer gets to set, these are the hours that we want work done. And so you don't get to just choose or have your preference over what your accommodation is. So in this case, there was no real disadvantage to the family, right? This is a normal obligation where that parents all over the world have to deal with, and she could have, or they could have made arrangements to have their children in care before school. So when you're thinking about family status accommodation, it is not about preference, but about what is your actual need. And a lot of the times that will come into play when you're dealing with children who have a disability. And so there is some sort of requirement that it has to be the parent who is caring for the child, or the child has to get to medical appointments or certain types of treatments. And so the parent needs to be away from work. So it's not to allow parents to take their kid to hockey, but more to make sure that parents are able to take care of actual essential needs. And so I think I've said what we know for sure already. Accommodating requests to work from home. So we've touched on this. There is a case, and I'll just, I'll flip to the case that, is this the one with the head injury?
Yeah.
Yeah, I just want to see if this is the. Yeah, no, but there's one with the PIP. I'm gonna go right to the one with the PIP so that we can make sure that we talk about that one. So here's a case where somebody was a health service representative, and they had worked since, I believe it's 2011, out in the field. And so they would work from home on days that they weren't visiting different clients as a sales rep. And they even had a letter that said you're a field employee and things like that. The pandemic comes and everybody starts working from home. This employee then makes a request for accommodation because she is the caregiver for her parent. So again, you remember, family status is in a child-parent relationship. So in this case, it's caring for an elder. And her mom is going through cancer treatments. And so she needs to be able to take her mom to the treatments. Her father has passed away. Her sister is a teacher and is deemed an essential service worker and with children at this time. So COVID is still rampant. They're worried about someone with cancer because they would have a low immune system. And so she asks for the request in August. It's granted. And then in September, they put her on a PIP and they say, you know what? This isn't working. You're not meeting your targets. Your quotas are lower than everybody else. And they did have quantifiable information that would suggest that she was underperforming her peers. And then she says, well, I still need to be able, and then they introduce a memo that says everybody needs to come back into the office, including you. And she says, well, I'm a field employee, so I work from home. Plus I need to be accommodated because I can't be exposed to people because I'm caring for my mother who has cancer. Plus I have a child who is homeschooling. And so I need to be home because of that. And the employer says, no. The employer says, we will offer you flexible hours to attend your mom's appointments, but you need to be in the office on days that you're not caring on the days that you're not out with clients. And she ultimately files a complaint with the Human Rights Tribunal. And they say that that is discrimination based on family status, and that the company should have looked at the fact that she was never really an office employee to begin with. She could do her job from home. And they said that putting her on the PIP was actually a form of reprisal because they said that it was connected to the fact, at least in part, to the fact that she had requested accommodation. And it was based at least on part on the fact that she was working from home. So she got $25,000 in damages for the discrimination and the reprisal. And then she got $75,000 in damages for lost income. So big payout there. And maybe Lenny can do like a few minutes on bargaining.
Yeah, this,
Oh, yeah.
If somebody was given an accommodation by a previous manager and then a new manager steps in and recognizes that this is something that they can't accommodate anymore, can you change accommodate? At what stage can you change accommodation or not?
So you can change accommodation, but you're gonna have to show why. So, you know, why is it that you need, you have to change it? Is it because the first manager never actually went through the accommodation process in the first place and just said to the employee, sure, you can do that because that's what you've asked for? So maybe, so you can start the process from the beginning to say, please provide your rationale and the documentation and all of the things that we may need. And then you need to say, well, this is why the needs either of the company or of the group have changed. And I would say give notice. So you're not going to make the change immediately. You'll give notice that the change is going to happen in 2 weeks, 4 weeks, 6 weeks, depending on the circumstances.
All right, Lenny, what can you tell us in 4 minutes?
yeah, and I'll be quick here and some of this is just some cool charts that, well, charts that I think are cool because I'm a big nerd about this kind of stuff, but
True story.
Look, we're in very uncertain times, and I'm sure everybody said that for hundreds of years, but we are, right? We all know there was quite a shock to the system earlier this year, and you know, everybody was on pins and needles, right? And you know, throughout the pandemic, created uncertain times. All of this feeds into the collective bargaining context. No surprise, right? Everybody's feeling inflation, higher grocery prices, right? When it comes to bargaining, I would say bargaining tables are still very challenging, even though inflation is not, you know, 5, 6, 7% anymore. It's eased. We just saw an interest rate decrease last week, or a Bank of Canada overnight rate, excuse me, which will likely feed into lower interest rates, mortgage rates, but not always, right? There's still upward pressure on wages. The impact of high inflation is still working its way through the system, right? Employees are still coming to the table wanting catch up, perceived losses in real bargaining or real wage buying power over the last 3-4 years. What has all this resulted in? Well, if you've been watching the news the last couple of years, a lot more labor disputes, right? A lot more work stoppages. This is an interesting chart showing hours lost to labor disputes since 1946. And you can see the peak in the mid-70s through the 80s, right? When the oil crisis, 20% inflationary pressure, interest rates. In retrospect, what we've seen is that the 90s through the first 2 decades of the 2000s were relatively calm and stable. Right? It doesn't always feel that way in the moment, but when you look back, they were. The last 30 years has been very calm, and we see a huge upward spike over the last 3-4 years in hours lost to work stoppages. What does this mean in terms of settlement trends? Well, they're higher than they were over the last 30 years, right? When inflation was relatively stable, we saw deals at the table of, you know, 1.5%, 2%, 2.5% was high, maybe. In 2024, reported wage settlements, the annual wage increase is about 3% compared to 3.5% in 2023. And we saw a little bit of difference between the public sector and the private sector. The trend of wage increases in collective bargaining being front-loaded continues. So often the first year of the deal is a lot higher, and then you see it taper off over years 2, 3, 4. And that's because that's a sort of a catch-up, right? People are coming to the table, they're upset, unions are upset, employees are upset. Of course, there's many industry-specific dynamics, you know, where employees were coming off a long-term collective agreement. Maybe they feel like they're owed a lot more catch-up. Maybe employees in a short-term collective agreement, you know, they haven't seen as big of an impact on because of inflation, because the deal was shorter. So settlement trends, if you're going to the table, expect the union to be looking for quite a bit of catch up. This chart, just inflation versus wage increases. You'll get the deck after, but it just shows that generally wage increases trail inflation, which of course makes sense, right? You don't negotiate anticipating huge inflationary increases. You negotiate collective agreements 2-3 years out for the most part. So oftentimes inflation will occur, and then, you know, afterwards you assess whether the wage kept up with inflation. So some trends at the bargaining table. Well, what I've just talked about, people are pretty upset still, and we're seeing this anger being taken out at employers at the bargaining table. What I would say is too, this is my own commentary, but I would say unions in general having trouble controlling this, right? People are so upset, and you know, in the past, unions are recommending deals. Some of these deals are being voted down after being recommended by the union's own committee. I've seen a lot of this over the last 2-3 years. What it's resulting in is really lengthy negotiations, right? You're seeing unproductive behavior at the bargaining table. And some of this may be generational changes. I don't know what generation we can blame anymore, Gen Z or whatever, but there's generational changes and things aren't, you know, I think that's impacting. There's tension. And unions are less top down in terms of control, perhaps than in the past, right? A lot more bottom up, maybe, in terms of membership participation. We've already talked about this, but remote work is making its way to the bargaining table, right? We're seeing this, unions are proposing remote work be codified in the collective agreement to give them that hook of an entitlement. Some other trends, unions might be pushing for long-term deals. If the offers are higher than prospective inflation, they want to lock in those guarantees. Although with the uncertainty, you know, some unions are saying, okay, do we do short-term deals and then come back to the table? Signing bonuses are back, right? Those went away for a little while for the most part, but I think signing bonuses are being agreed to in many cases as those forms of catch-up. I don't know about what everybody else is seeing, but I'm not seeing any early settlements. I think if a union signed an early settlement, you got to be scratching your head and be like, what's going on, right? Hard to sell to their membership when they take the first deal, kind of thing. Cash is king. People want compensation increases, monetary increases. Seeing some cost of living adjustments again. These were big in the 80s, went away for a long time. COLA clauses are back again. This is just some concerns for employers, largely about what I've already mentioned here. Unions have big demands. They're coming to the table. We're seeing work stoppages when we didn't see them before over many issues. If you're an employer and you're not caught by Hilda, for example, engage in some contingency planning, that a work stoppage could be real. Technological changes occurring now more than ever. There's this little thing called AI. I don't know if anybody's heard about it, but it's impacting the workplace and it's coming quickly, and unions are scared of it and they want certainty. They want notice about changes. They want to talk about it. They want to know what the employer has in store, what they're planning, what they're looking at. And couldn't end the presentation without talking about our neighbor to the south. And I mentioned this because in a recent interest arbitration from last year, you know, the employer was arguing, well, we're in a more stable environment right now. Inflation's tapered off, and the arbitrator said, well, we have an interesting neighbor down south that's created lots of unpredictability when it comes to trade with Canada, for example. So the last line is relevant here, is that one cannot say for certain that inflation will stay close to the Bank of Canada 2% target. And so again, if there's any sort of takeaway from this little segment of the presentation, is that there's a lot of uncertainty. And if you're entering into collective bargaining, I would say now more than ever, plan, and map out a lot of scenarios and contingency plans. So.
Thank you. Thank you very much, Lenny and Aaron. I'm sure they'll be hanging around a little bit here for people in the room who have more questions, and online, if you have questions, just submit them to the Q&A and we will get them to Aaron and Lenny to reply to later. We're running just a few minutes behind, so let's take a 10-minute break now and we'll sign back on at 10:45. Thank you.
So I think we'll draw people back from break time and get started just momentarily.
Okay, everybody, thank you for tuning back in, getting to your seats in the room. And we'll pick up our session now with just a short session on substitute decision makers and privacy matters. I nearly said privacy makers, privacy matters. And we'll turn it over to our health associate, Heather Whiteside.
Thank you, Lynn. So as Lynn said, I'm going to chat with you today about substitute decision makers, specifically in the privacy context, and specifically questions about who has the right to access health information about individuals, whether that be a resident of a long-term care home or a senior who's receiving home care in their home. So who has the right to access health information about them and to make privacy decisions relating to how their health information is used and disclosed. So these questions arise in circumstances where individuals have capacity, and perhaps more obviously in circumstances where individuals don't have capacity and therefore need someone to act as their substitute decision maker on their behalf. So I'll start with just a very brief overview of sort of the legal lay of the land from a privacy perspective, just so we're all on the same page. Then we can dive into some of the more specifics about who can act as a substitute decision maker and what their responsibilities are. And then I will end with a little case study based on a recent decision from the Information and Privacy Commissioner of Ontario that speaks to some of these issues, how they play out in practice, particularly in this case relating to individuals who are deceased. So in Ontario, as many of you will know, health privacy is governed by the Personal Health Information Protection Act, or PHIPA. This applies to health information custodians who are collecting personal health information in the course of providing healthcare. And healthcare is defined very broadly, and so applies in many cases when we're talking about seniors housing. And so the types of organizations that you see listed here are considered health information custodians and therefore subject to this health privacy law. So retirement homes, long-term care homes within the meaning of the Residential Tenancies Act, and of course, health service providers who might be providing care or providing seniors with home and community care. In addition to PHIPA, there are also privacy rights enshrined in certain other legislation that's applicable in this context. So for example, the Resident Bill of Rights that's set out in the Fixing Long-Term Care Act. It enshrines as a right for residents the ability to be able to meet privately with a spouse or another person in a room that affords them privacy, and also sets out the right to be afforded privacy in treatment and in caring for their personal needs. Similarly, the fundamental principle that's supposed to guide the interpretation of the Retirement Homes Act is the idea that a retirement home should be operated in a manner that creates a place where residents can live with dignity and autonomy and respect and privacy, among other things. So going back to PHIPA, one of the key principles under this act is consent. And so that means that custodians, so any of the entities you see listed here, need to have the consent of the resident or the patient or the client in order to be handling their health information. The idea is that each individual should have control over how their health information is used, and they should control similarly who it is shared with. A second core feature of PHIPA that's relevant for our discussion today is that it also provides individuals with the right to request access to their health information. So access to information that is retained by healthcare providers or long-term care homes that are providing them with care and services. Now, PHIPA sets out this regime that governs who gets to make decisions about privacy matters, whether that's in the case of individuals who have capacity or individuals who don't have capacity. So let's start with individuals with capacity, and surprise, surprise, it's usually that individual who gets to make decisions about providing or withholding or withdrawing consent. And also it's that individual who gets to exercise their right to access their personal health information. The default is that every one of us in the room would be presumed to be capable of making these sorts of privacy decisions unless there's reasonable grounds to believe otherwise. So, a diagnosis of advanced dementia, for example, would be a pretty obvious example of where there would be reasonable grounds to believe that someone is not capable of making that decision. Of course, though, in the long-term care context and other forms of seniors housing, it's not uncommon for individuals who have capacity to also still be supported by caregivers or family members or friends who are involved in their day-to-day care or decisions or want to provide input or being asked to facilitate appointments and things like this. And so individuals with capacity can authorize someone else to act on their behalf, to make decisions about how their health information is handled. So for example, in the case of a healthcare organization that might have a patient portal where individuals can log in to book appointments or access their health records, that person may have the client or the patient has capacity, they should be able to delegate someone else who can access that portal on their behalf if they don't have the technological means to do so. So someone else can make those arrangements on their behalf. Now, there's a different regime where individuals are incapable. And in this case, an authorized substitute decision maker can consent on their behalf and can exercise these access and correction requests that I've been speaking of. Now, incapacity is a formal determination. It's often made either by a healthcare provider, like in sort of on a case-by-case basis, as that healthcare provider is looking to obtain informed consent. It can also be made by a capacity evaluator if it's needed for as part of a legal process. In any event, PHIPA lists, as you'll see here, the individuals or the persons who are authorized to act as someone's substitute decision maker in this order of priority. So from the top down, for most people, that means you automatically have a substitute decision maker. It's usually, your closest living relative. And this doesn't require any kind of legal process. That's just the default. In other cases, some people will have a legally appointed substitute decision maker. So by virtue of some legal process, either a legal document like a power of attorney or a court order that appoints someone as their guardian, you may also have legally appointed substitute decision makers. I will say this gray box at the top here is worth flagging. What we're talking about here, substitute decision makers under PHIPA, we're talking about decisions around personal health information. And many of you may be familiar with substitute decision makers under the Healthcare Consent Act, where decisions about treatment or admission to a care facility or the receipt of personal assistance services, those in connection with those decisions, people may also have substitute decision makers, and PHIPA defers to a substitute decision maker who exists under the Healthcare Consent Act. So for example, if a resident has a substitute decision maker who's making decisions about their admission to a care facility, then necessarily that person is a substitute decision maker for the purposes of PHIPA, insofar as information is necessary or related to that decision about admission to a care facility. It sounds sort of complicated, but in fact, the list of individuals who can act as a substitute decision maker under the Healthcare Consent Act are essentially the same as what you see here. So there's not much conflict, but these are, as I say, the list of people who can act in this order of priority. At the very bottom of the list is the public guardian and trustee. And so in cases where there are no legally appointed SDMs and where there are no living relatives who are available or able to act, then as the last resort, the public guardian and trustee can step in and act as someone's SDM. So let me flag a few considerations or questions that might come up when we're thinking about who can act as an SDM and what they're supposed to be doing. First, in addition to being the person who's highest ranking on that list that we looked at, a substitute decision maker has to be themselves capable. They have to be at least 16 years of age. They can't be prohibited by a court order that would prevent a separation agreement that would prevent them from accessing the individual. And they have to be available and willing to act in this capacity. So those middle two criteria, I think, are generally self-explanatory, but sometimes in the context of seniors care, the first and the last might raise some more nuances. So capacity, we're usually focused on whether or not the individual, the patient, the resident has capacity, but sometimes it may also be necessary to think about circumstances where someone's spouse is acting as their substitute decision maker. Providers also have to be aware of the capacity of both of those people in those circumstances. The second point here relates to really the primary responsibility of a substitute decision maker, and they are tasked with acting in accordance with the wishes and the values and the beliefs of the individual themselves and not their own. So this might be based on verbal statements that the person made while they had capacity, or written directives that were made as well. So for example, if an adult child is acting as a substitute decision maker for their parent and knows that their parent is not interested in invasive medical treatments, then it would likely be inappropriate to be providing their health information to a practitioner who specializes in those sorts of treatments. It's subjective, it can be tricky to determine, but if a care provider is in a position where it seems like there may be some tension between these values and objectives, it's worth clarifying, reminding that this is what a substitute decision maker is supposed to be taking into consideration in making these decisions. And as in a worst case scenario, a provider can apply to the consent and capacity board to have these to determine whether or not the substitute decision maker is in fact acting in accordance with the individual's wishes and beliefs. Something that comes up in the context of family members is where there are multiple equally ranking substitute decision makers. So you might have this where a resident has 3 adult children. And so technically they all have the same right to act as a substitute decision maker on behalf of their parent. And ideally would do so in a way where they're building consensus and in agreement. In practice, often you might have one person who is taking a more active role and who is involved in day-to-day decisions, and that may be fine. But it's important in cases where one equally ranked substitute decision maker might want to defer the decision to someone else, or in any cases where there may be room for disagreement, it's important for providers to know who's in the picture and who has the authority to make these decisions. And I suppose, again, in worst case scenarios, to remind equally ranked substitute decision makers in the case of a gridlock that the public guardian and trustee would be the one to make the decision if those individuals aren't able to come to some sort of consensus. So let me finish with an example of how some of these issues might play out in practice. And I'll preface this by saying that substitute decision makers effectively step into the shoes of the individual, and so they can make the decisions and exercise the access rights and consent in the way that the individual would have been able to themselves if they had capacity. And that's different from the regime under PHIPA that allows long-term care homes and care providers to, in very limited circumstances, disclose health information to other third parties without someone's consent who may or may not be a substitute decision maker. And sometimes this distinction between those two sort of sets of rules causes some confusion. And that's what we see here in PHIPA decision 228, which is the decision of the Information and Privacy Commissioner of Ontario, who has oversight of PHIPA and can adjudicate complaints from individuals or their substitute decision makers about how organizations are handling privacy matters. And so in this case, a complaint was made by the executor of an estate who had made an access request to a long-term care home to receive health information and information records related to certain incidents that had happened at this long-term care home following the death of a resident in the long-term care home. And the care home initially refused the request, in part because they said the records weren't health information, they were about employees, and in part because they took the position that there were no grounds under PHIPAA that would allow them to disclose information after this person had died, and an executor of an estate did not have this automatic right to access records about the former resident. And so the custodian in this case, the long-term care home, was really focused on this sort of disclosure regime under PHIPAA. They weren't thinking about who the substitute decision maker is of an individual who is deceased. And when an individual dies, their substitute decision maker is the executor of their estate or whatever other person is responsible for the administration of their estate. So whether or not they had capacity or not prior to their death, and whether or not they had another substitute decision maker, you know, one of those people listed on the list we saw before, that sort of falls by the wayside. And for deceased individuals, their substitute decision maker is the executor of their estate. And that person does have a right to make access requests. The motivation, the reason that they're wishing to access those records is not necessarily relevant, but that is just a right that they're able to exercise by virtue of the fact that they're the substitute decision maker. So with that, I will leave you and move on to the next part of our session.
Thank you so much, Heather. Does anyone have any questions on that for Heather? Okay, great. Well, thank you, Heather. That was very good. And we'll now invite our panelists to come forward. The worked for government, later became an advisor to government, is now a lobbyist to government on behalf of the Ontario Long-Term Care Association, where she is the president. Donna also has sort of frontline experience being the CEO of the Hinks Delcrest Center, provides mental health care to young people. She held that role until it merged with sick kids. And then Farah Ismail. Now, Farah is my newest friend among this table, but still a friend of a few years. And Farah is a nurse by training as well as a lawyer. And was it 3 years ago you joined SC Health?
It's been almost 7.
Almost 7 years you
Yeah.
joined SC Health. And she teamed up with John Yip. Some of you may know John. John has very ambitious transformational plans for SE Health. And all of us who've been in healthcare a long time know St. Liz Health. And but the current SE Health, I think, is quite different than the organization we all once knew. As I say, very transformational. So Farah is heading up the legal department there, which is growing and is dealing with a lot of operational issues as well in the long-term and senior sector, both home care and long-term care. So this is our panel. We're going to hear first from Lorna, and then from Donna, and then from Farah, and then we'll get into some discussion. So ladies, just make sure that your little mic here is on green when you speak, and you can leave it on the table. I'll leave it to you. So over to you to begin, Lorna.
Thank you. You're all fortunate to work with Lynn, and she's been a great friend and wise woman. Yeah, my journey into long-term care and into this whole sector was never, of course, in our life plan, but that's what life happens. And so my husband passed away 5 months ago from Parkinson's and a Parkinson's-related dementia. And it was our family doctor who said, you are going to need home and community care in your house. Our family doctor diagnosed him with Parkinson's, and it all went just so quickly. He was a very healthy guy, runner, all of that, but Parkinson's isn't a respecter of that, and neither is a Parkinson's-related dementia. And so, yeah, it was our family doctor who passed us a home and community care form and said, you have to fill this out. You have to start. And we were like shocked that we might actually need people to come into the house to care for us at our age. Anyway, the disease ended up costing both of our jobs. We just knew to do it well, we should quit work, and we were able to do that. And we had a really good year. And then boom, all of the people coming into our house, we eventually built a suite, had a live-in person, maxed all our hours out until just over a year and a half ago, my husband collapsed at home and was hospitalized, and his brain had stopped talking to his legs and other complications. And so he was the one who said, we can't do this at home anymore. And he wanted to go into what he felt was a safer, less, I don't know, whatever. He was thinking of me, obviously. And so I was in an advanced dementia care class with Acclaim Health at that time. And in that class, 3 families of 12 of us had hired lawyers to manage how they were going to get into the long-term care home they wanted. Families like us are like activists. Like it is like we kind of lose our own minds in saying, this loved one is too young for this. We need care, and we're going to make sure our tax dollars pay up for us. So it's quite a snarly group, really. It's I would describe us as, and I was fortunate. I found, and we all found, that once you're in hospital, the social work team is a gotcha. So the nice friendly thing that happened in the community where you were just grateful for whatever hours could come and you worked it all out. In the hospital, it is like, how fast can we get you out of here without your choice, without where you're going to go? The rest of your life is now in our control. And they do it over your husband's bed. Everybody talked about that. It's a gotcha thing. All of a sudden, some sweet ladies walk in, you're visiting, and bang, you're going to life plan right now. And so it takes a real, the negotiations for us as families begins early, like right there in the hospital. I'm sorry, could you book that as a meeting with me? And could we have a private room, please, to have this discussion? And so it's a lot of, it's more combative than you expect it to be. Anyway, once you get the lottery ticket of a long-term care home, another journey starts. And I was fortunate because I paid for a private facility in a Schlegel village that had a memory care ward. And the hospital, as part of the negotiating, put a 24-hour PSW support around Vern because his needs were so high that they couldn't be handled in that facility. And within 1 month, we got a bed in a long-term care home, a 7-minute walk from my house. So it was very easy for me to become an activist to help help lead the family council, all of that. And I would say that only 5% of families in long-term care are activists, like harsh activists, calling for inspections, calling like it's, they really, people who go daily, they are the ones that become the activists. And you can feel the tension. You're very grateful as a family that there's this place. You're very grateful the PSWs care and want to do their best, but you can feel the tension of this has to be profitably or profitable enough to make it work for the owner and for the operators. And so you're kind of caught in this tension of appreciating them greatly, but also really knowing that you get 4.5 hours of care is legislated, and also the allied health professionals. And so we had a recreation room which was completely unused until families really, until we said, why can't we get therapy in there? Why can't we? And so it's this tension that families and ownership lives. And end of life is shocking, actually, what happens in long-term care. And so I'm not alone in this because we have discussed this as a family council, but you go to hospital doesn't want to keep you. Hospital discharged Vern. I didn't even sign a consent, or I didn't sign anything to have him discharged. He was just taken out. And our long-term care at that time had a non-working elevator, and I was really worried about him getting carried up in a gurney. But that's what happened. And you think long-term care is going to be palliative, but there actually is no doctor on site. So you don't know, you don't realize you're going to go into the last days of his life with you making the calls, your adult kids, that whole decision maker thing, not sure mom's doing her best, all of that. And I have seen as family council chair what happens when there is that lowest rung on the ladder as the substitute decision maker on end of life for a person. And it's a rough ride. It's a really rough ride watching that happen. So family councils aren't near as robust as they could be. It's a little bit like homeschooling or that kind of thing. You've got so many responsibilities. You don't have time to also be in the front line of family council. And so many homes don't have a family council. But it's this tension between you're just so grateful that you got a bed, and yet we need to tweak a few things. So that's our story.
Sorry. And Lorna, just tell everyone how old was Vern when he was diagnosed.
He was 58 and he passed at 67. Yeah, and we did everything to try to keep it at bay and all of that. But it's just that some diseases just move aggressively fast. And it was actually our physiotherapist who said, you need to put your name in at Baycrest Memory Care to see a gerontologist there to help with the disease. And it was a psychogerontologist. It was excellent, Dr. Verhoof. And he would spend well over an hour each appointment we went in. And he was the one who said, here we're young, and he said, you are going to need a long-term care home. This disease will not be able to be managed at home. And, the shock of but it's a long on-ramp that we should be prepared for.
Well, I think what you would have heard in Lorna there is what we all hear so much. There are so many things to be very grateful for in our healthcare system, and yet there is much improvement that could be seen, and the tension. All right, Donna, you get to see this from a province-wide, big picture perspective, and
yes, and I've lived the dream myself too, in my own family experience, and it's not an easy one. I actually see huge parallels between the mental health sector and aging, the stigma around long-term care, the stigma of growing old. We don't want to talk about it. We don't want to plan for it. We don't want to have those conversations. We've talked, Lynn said, I mentioned I've worked in government in the 90s. We were talking about the silver tsunami in the 1990s, and yet no government anywhere has actually planned for the baby boomers to age. And our oldest baby boomers are now 80. And in 2027, in Ontario alone, the population over 80 will double. And we have made no contingencies anywhere for this to happen. And remarkably, the baby boomers themselves haven't either. So 2 years ago, we worked with Abacus and we surveyed, I think about almost 2,000 seniors in Ontario between the ages of 65 and 75 to find out what their expectations were about aging and what plans they've put in place for their own aging journey. And unremarkably, the majority, more than 80%, had said that they are not going to get sick. They will not require specialized care. So they didn't want to talk about it. They did not want their kids to have to look after them at all. So they had not had conversations with their children. So substitute decision makers, many of them didn't have wills. They hadn't even planned for any kind of specialized family supports. Very much ahead in the sand. Not going to talk about it, not on my radar screen. I'm going to age in place, where aging in place really meant aging in my family home. So we recently went back into the field and we surveyed 6,000 residents across Ontario, across 6 different geographic regions, trying to figure out if there's any sort of variance for rural, urban, the GTA. And this time, there was more recognition or greater recognition that they might need care. However, they still felt that it was up to government to solve the problem. They have not planned for it. They still, even though they might need care, no consideration for what Lorna and her husband had done in terms of planning financially to think, okay, if I am going to age in my own home, I may need to supplement care from provincial home and community care supports. But where the public landed though was it is up to all levels of government to make sure that the services and supports will be there for me. So we asked the question, okay, so let's go through a prioritization exercise and in the polling exercise. So could you weight access to care, affordability of care, and quality of care? And across the province, everyone said exactly the same thing. My expectation is that I will have access to high quality care in my local community when and where I need it. And affordability meant it would be publicly funded. So completely agnostic as to whether or not, as to who provides the care. So it could be privately delivered care, but everyone agreed had to be publicly funded. And there was no variance. It's quite consistent. The expectations were access locally to high quality, publicly funded care, regardless of where they lived. And this is going to be a real challenge for governments. We also asked them about which level of government was responsible. And the expectation was it was all levels of government. I'm an independent taxpayer. I pay my taxes to all levels of government, and I'm going to hold all levels of government accountable. So even from that political domain, we saw that Prime Minister Carney was elected by baby boomers. So we know that the baby boomers at every single stage and phase of their lives influence what happened. So whether that was building factories for diapers, building new universities, new schools, this is their moment now. And yet no level of government has actually prepared for this. So nowhere in Ontario. Ontario's not ready. Canada is not ready. The United States is not ready. And I sit on the board of the Global Aging Network. The United Kingdom's not ready. The European Union's not ready. No one is ready for this. And so, politicians are going to be, I think, as we plan for 2027, are really going to be challenged because it's going to be voices like Lorna's, where suddenly individuals are going to need care and they're not going to be able to access it. And they're definitely not going to be able to access it locally. The wait list for long-term care in Ontario is 48,000 people. And we're holding steady at that. And the reason that the wait list numbers are not growing is because people are dying on the wait list. They are not accessing care. So, our question is, well, what's happened to them? Because we know that activist families are very rare. So what is happening for individuals in rural communities where they may not have access to care? We know that in Toronto, the bed census for long-term care is about 15,000. The wait list is 9,000 to access care in Toronto. And what is happening is, with the aging demographic really putting pressure on the hospital system, hospitals are controlling access to long-term care, and the choice is being taken away from families. So the exercise of ranking a long-term care home to prioritize is a moot exercise, because it will be the hospitals who will decide. And most often they will discharge those who are less convenient to care for. And what we're certainly seeing right now is we're seeing an increase in the number of individuals who may be street involved, have mental illness and addictions, have behaviors where the hospital really wants to prioritize the discharge of that individual. And the families really don't have a choice anymore. I was actually speaking at a nonprofit AGM earlier in the summer in Minden, and they have residents in their long-term care home from Brampton and Mississauga. And that wasn't the family's choice because they have a cottage or a family member in that community. It was because that's where there was a space. So when we're looking at the pressure on the system in Toronto, and just by virtue of the aging demographic, that population over 80, the pressure on the entire health system is really going to be brought to bear over the next, I would say, 12 to 24 months. And so there is going to be greater intolerance because we do know, and the data will bear it out, that while we all want to age in place, and the majority of us will be able to, 20% of the population over 80 will require more specialized long-term care. So we need to make sure that it's home and community care and long-term care and primary care. And where policymakers always deflect is, okay, we're going to focus on this piece of the system today. So it's primary care today. And even earlier, looking at the collective bargaining, so the government wants to hold the hospitals to a 2% increase. When you look at those arbitrated awards, that's not viable. So even in terms of putting investments in long-term care to ensure that the supports are there, I think we're really going to, austerity budgets aren't going to work, because the tolerance of family members who are trying to navigate the system, who want to work, but maybe a family caregiver where their parents haven't prepared them for that journey, and suddenly they're thrown in as caregivers in the home environment. So it's going to be a real challenge, I think, for politicians, because instead of, in Ontario, we really don't have an opposition party right now. I do believe that the opposition party will become the family members who are trying to navigate the system, who are trying to work, trying to maintain their jobs, but also have a family member who's aging and cannot access care. And if there aren't enough hours in the publicly funded home and community care system, and there aren't enough staff members. So I think we are at this, I would actually say it sounds terrible, but this is a moment of an opportunity for sort of really meaningful structural change. The government of Ontario, I will give them real credit. Unlike any other jurisdiction, they actually responded to what happened during the pandemic. And no one really knew what long-term care was before the pandemic. No one had a sense of who was living there. We were all afraid, didn't want to go in the doors. Long-term care in Ontario today is not the long-term care of 2020, thankfully. And it's through broader family engagement, but it's also through billions of dollars of new investments that the Ford government has put into the sector. We have rebuilt homes. We have at the pandemic, we had 627 homes in Ontario. Today we have about 620, so we have fewer homes. We've had home closures, but we've also had redevelopments. And we still have 200 homes across the province that need to redevelop. And unfortunately, the pressure on the system and the inability geographically where we have not been able to rebuild or build new capacity has been in rural communities and the GTA. So when we think about the pressure on the Toronto system, this is going to have huge reverberations. So the government has put a lot of money in. We have a lot of activity and transactional based policy decisions and investments in new PSWs, in nurses, nurse practitioners, new med schools. And we do know that we have a lot of homes that are actually in the process of rebuilding across the province, but not necessarily where we need them. And we haven't really factored in the health human resources element of it either. And so we have a workforce, a younger workforce that wants more flexibility, that actually doesn't want to be unionized, that wants to, so the travel nursing phenomenon is really emerging, where the nature of work, they want flexibility. Individuals want to work when and where they want to work. They don't necessarily want to wait for seniority before they actually take on a new job, like before they can take vacation. They want to take vacation when they want to take vacation. So we're up against this generational divide as well. And I think we do need to think about how do we share a workforce, not only across the country, how do we think about new approaches to care? We know that those individuals coming into long-term care homes are far more critically ill. They have multiple diagnoses. Most of them have advanced dementia. Where we have younger population, we need to think differently. We need to look at a differentiated long-term care system where perhaps we have more specialized psychiatric long-term care under the Mental Health Act, as opposed to the Fixing Long-Term Care Homes Act, different communities. And if we are going to take more of a population-based approach, we do need to think differently. But remote monitoring, why can't somebody in a long-term care home in Elgin County be monitored by somebody at London Health Sciences Centre for cardiac monitoring or for their diabetes monitoring? How do we share that pool of specialist doctors? There are a lot of pieces that are in play, but I would say that it's whoever has the ability to actually knit the pieces together in a coherent vision and drive change with new innovative models. I was a client of Lynn's when we merged the Hingsdale Crest Centre with Sick Kids. I think we're going to see more consolidation in the health system, new innovative models, which aren't necessarily hospital driven, but even long-term care hubs. So where long-term care homes could actually rebuild with a family health team, with a pharmacy, with diagnostics in a local community, have housing for students and staff, and really start to think about what do people in the context of their families and their local communities want, and what are they going to demand? And that is going to drive decision makers. It's not going to be about this piece of legislation or that one that is creating barriers for more distributed care models or integrated care models, where you have to look beyond the funding agreements and really think about how do we build something in the context of somebody and what their local needs are, and how do we look at those assets more broadly. So it's a time of opportunity and excitement to be creative.
So much there to unpack. That was great. Thank you so much, Donna. Farah, I think those, Donna's mentioned some challenges, and I think SE Health is actually taking some of those on. So
That's right.
why don't we?
Yeah, so thank you both to Lorna and Donna for your comments. I think you've set it up so that the picture is painted pretty clearly. At SE Health, we are a national not-for-profit social enterprise. So while today I'll focus on a lot of the Ontario work that we're doing, I think across the system, there is opportunity for broader connection. And because of where we're positioned, we have the ability to sort of scale what we're doing in one area in other jurisdictions. So, you know, I too am currently navigating the scenario around long-term care for a very close family member. So what you have shared is really happening. And unless you've got a voice at the table, it's very hard to drive change or have impact. And so I think what we're doing at SE Health is we're looking at all of these things in some sort of way. And so, you know, Donna, you outlined a few different things, and I'm just writing notes as we go here so that I can maybe share and highlight some of the initiatives we have taken on to try and bridge that gap that we're seeing across the system. So I put this into 4 different buckets. The first area is really around patient experience. They are the people that we're providing care to, and I think they're the most important bunch. And if they are not getting what they need, then it's incumbent, I think, on the service provider organization to be listening to that. So what we have really put focus on is developing our first ever actually patient experience office at SE Health. It sounds wild that we're just doing this after 117 years. It's not that we haven't been focused on patient and family centered care, but we're actually building an arm's length entity to help support our patients navigate this process. I'm really pleased to report we've almost landed it. We have an executive director position that we were hiring for, which we hope to have someone in place, you know, in the next couple of weeks. Lots and lots of interest across the spectrum of healthcare providers, but also patients themselves who have navigated these things. So there really is an interest and a desire, and the patient experience office is really going to be 2-pronged. It's to obviously hear about the patient's experience, navigate the challenges that they've faced, help really provide that support to them, but also about engaging them to see what it is they need to have in order to be able to navigate the system more broadly. And because SE Health is positioned in a really unique place, we not only provide home care, but we have hospital partnerships. We do operate in long-term care. We have, you know, a college program where we're educating our healthcare providers to deliver good care. So there's lots and lots of reach across the spectrum. And so I think we are uniquely positioned to be able to support that. The second bucket that we look at, we are in a human health resource crisis right now. There is a shortage of care providers across all of healthcare. And so some of the things we're doing is we've really looked to enhancing our recruitment and retention strategies. We have something called the people everything approach. And really our philosophy is this: if we take care of the people that are providing care to the patients in the community, they in turn will take better care of the patients that they're servicing. So this is, you know, we have seen a collective improvement as we continue to focus and enhance the priority of our people. They are delivering better care where they're positioned to. The other thing is we're focusing a lot on training and remediation. So, you know, the connection with the regulatory bodies, for example, you take the College of Nurses, good and timely reporting. I think that employer-provider relationship is really important to ensure that we don't have people who are providing substandard care. Where there is a risk, it's actually getting addressed. And if the individual needs further training or development within the employment context, they are getting that because we're on top of it. The other thing that is emerging across the system, and people might be attuned to this, there's a desire to regulate our PSW population. So those are personal support workers. Now, while that is, I think, really, really important, to develop standard practice, I think it's really, coming at a difficult time, I think, from an employment perspective, because PSWs are probably paid the least within the system, and with them being regulated, there's a cost associated with that. So that then again could be borne by the employer. Also, it's not mandatory for them to be licensed to practice yet, so that inconsistency will drive sort of a divide between this level of expertise. Some of the other benefits that I thought I'd just share in and around our focus on our people is we've done things that are unique. The caregivers that are actually providing care are also in this situation. They are navigating long-term care or caring for their elderly parents. And so we've designed a caregiver benefit in partnership with Green Shield, who's our benefits provider. And so we are providing this respite care that's a part of a benefit. So again, trying to take the burden off of our care providers so that you can actually provide better care to those that they serve. We're also doing some unique things such as a car loan program. So facilitating the ability to actually purchase a car so these individuals aren't burdened or strapped for doing, something that they need in order to get around to do their work. The third area that we're doing, we've just launched a housing or a housing accessibility model. And so again, supporting people to get small loans to be able to purchase or to pay rent in a particular area for their own personal housing, so our employees in their own personal housing. We also, this isn't a model that we have in Ontario right now, but out west, we have developed an employee residence. So there's a long-term care facility, and just across the road, there is actually residences for our employees to live so that they don't have that extra burden of the commuter travel to work. We are also obviously doing some other things around management and advisory services. So as I mentioned, we do operate in long-term care. So we've been called upon by the government of Ontario to provide advisory services in long-term care homes that are not operating at the right level. And so with the skill and expertise we bring to the table in terms of, our HR operations, our policies and procedures, we're providing the guidance and input to help manage these long-term care facilities that haven't been operating in a great way. And then finally, the last bucket I wanted to talk about a little bit is alternatives to care. So we have a model, again, this is out west, but it's a small homes model. And so these homes are in Alberta, they have different funding. It's different than Ontario, but these homes actually provide more of a home. It's almost like a little home with, maybe 5 to 10 residents with, around the clock care. That model is thriving in that region. We would love to be able to scale that in Ontario, and we have great examples of it working in Alberta. We're using technology a lot. So I think you mentioned technology and monitoring. So we have done a lot of hospital to home programs. So getting people out of hospital into the home, but not necessarily into long-term care, because some people don't want that shift, nor do they need it. And so how do we continue to support them in the home effectively so that there isn't an inordinate risk? I think we also offer private care. So again, we talked about the public and private split. So there is a lot of opportunity there to provide what it is the individual wants or what it is that their family has decided for them. So, it could be supplemental care that's being provided and paid for personally, in addition to the government funded model that exists. I just think that we are trying wherever we can to bridge the gap that exists across the system by really looking at, one, the patient experience, number two, the employees that provide the care, The third is, just in and around management and advisory services that we can provide given our expertise in the area. And then finally, the alternatives. What does it look like? Not everybody's journey will be the same. And so someone might really want to age and die in their home. And if there is availability to do that or supports that our organization or other service provider organizations can provide, then that should be something they should be able to elect to do. So I think that's, sort of the general overview of what SE Health is trying to do and to help mitigate some of these gaps. And also happy to answer any questions about what I've shared.
Well, thank you for it. It's very inspiring listening to some of the solutions that you're putting forward at SE Health. I wanted to pick up on the subject of the workforce, and I want to start with Lori's talk this morning, where she was referring to the 4-hour minimum per day of PSW and nursing care that residents of long-term care homes are to receive. Now, Lori told us the legal technical requirement today, which is that this is to be an average of 4 hours a day across the entire province, which I would think is cold comfort to somebody in a home that, where they're not getting 4 hours per day per resident. And Lorna, I think that this was one of the issues that your family council took on.
Yeah.
You want to speak
Robustly.
about that?
Actually, we understood it to be 4.5 hours a day is what you're legally allowed. And so all we had to do as a council is add up the PSW staff that we were there and, just crunch the number and found, oh, wow, we're short. And we did like a 911 call right to wherever we could find in long-term care and activated an inspection. And we had a new staff member hired within a month. And that is active staffing. And so, families, we watched that. That was, and so that does sound like a lot. Like 4.5 hours sounded like, if we could just get 4.5 hours, we'll be great. But it does actually take that. And especially if you don't have a family member who can help with the feeding or things like that, it does take that. And that includes their breaks. And so, it's families are well aware of it and they're pushing for it. And also of allied health professionals, supposed to get 40 minutes a day of allied health professionals, which can be anything from speech pathology to exercise to recreation, music therapy, all of these things. So, it's very empowering to families to know that those are legislated requirements.
Donna, I remember having lunch with you when this was first announced and us saying, how are we ever going to get enough workers to meet that target? But from your perspective, they're pretty much meeting it. They're very, very close to meeting it across the province.
It's a provincial average, and really trying to recognize that there are individuals who will need more than 4 hours of care and will need a lot more hands-on care. And so being able to factor in a lot of one-on-ones, whether that's for behaviors or others. Remarkably, the government is about, I think they're about 98% of the way there.
And they report that.
And they report
Yeah.
it. So there is transparency. I think, again, the voices of families are going to be even more important in this in terms of that transparency and accountability. Again, the more people who come into a long-term care home, and one of my missions in life is just as with mental illness, where I've spent a better part of my career tearing down the walls around the asylum. How do we open up the doors of a long-term care home and have more people come in? So even thinking about different approaches to those models. So if you had a family health team co-located in a long-term care home, to your point, Lorna, you would always have staff there. So you would always have a doctor on site. You'd have more allied health professionals, more nurse practitioners. The government's doing a good job, I would say, in investing in this. I think the challenge is going to be, how do we not lose ground? One of the things I always worry about is we don't factor in attrition. We've got an evolving workforce. long-term care work is heavy and it's hard. It's very difficult work. AI is not going to replace the need for hands-on care. And so how do we not lose the progress that they've made? Recognizing that as individuals coming in direct from hospital are coming in with more critical and chronic diseases and diagnoses, they will need more care. So at some point, that 4 hours, while it's aspirational now, it's going to be more of a specific demand just to meet the clinical needs. So again, how do we think differently about how we use a workforce? How do we rebuild a workforce? Our border communities, we're competing with US still for nurses. So we know that nurses are migrating because they're getting paid more, for instance, in Detroit than they are in Windsor or in Buffalo than they are in Niagara. Nova Scotia is being very aggressive on recruitment and retention of nurses, including with immigration. We know that the federal caps on immigration are having an impact. A lot of our homes relied on temporary workers and internationally educated nurses, and that has been compromised by the federal immigration changes. The closure of some of the partnerships between colleges and private career colleges. There's one, Trios and Mohawk had a partnership where they were educating 6,000 PSWs a year. That entire program's gone. So we need to think, I think we all have a duty to make sure that we are going to be able to meet the needs of this demographic.
Farah, I know I was going to ask you, Donna's touched on it, but the issue of the foreign temporary workers and the training of your college, these are both ways to get more workers in the system. So how is this going to affect your efforts?
So what we have done, can you guys hear me? It's working. Okay. What we have done, I think, around the immigration piece, we have actually brought in foreign trained workers. We've actually helped them settle in the country. They are working, they are being trained again to align with our practices here in Ontario or across the country. And now with these changing immigration policies, we're now seeing that, an impact of this because many of them are being forced back home. And so the reality of the situation is that there's been a huge investment, output of energy and time and effort by our organization to bring these people here, to settle them appropriately. And now they may be having to go back. And so that's just the reality. So we're working through the court system to figure out whether or not we can, argue this and see if we can have them stay in some way possible so that we don't have this major impact on the existing workforce that we have. In tandem, though, we've always had a career college, so we are training. And so through the pandemic, this became a really, really big deal. And so we were providing free education for years of service, like 1 year of service, so that we could really encourage people to take on, this new profession, like a PSW or healthcare aide, so that they could help to provide care to the homes that we service or in the community. So I think we are trying in every way to sort of make this work and to help lift the burden of the system again, even in terms of paying these individuals, because we're a not-for-profit social enterprise. A lot of the work we do is on social initiatives, and one of the initiatives is our people. And so, whether that be higher wages, sign-on bonuses, things like the benefits that I talked about, all of these things are being funded by our organization in order to help mitigate some of these gaps that we're seeing continue to rise as a result of where we're at.
I want to talk about the changing demographic of the population within long-term care homes. The average age that someone enters a long-term care home, I think, keeps getting older. I think it's about 84 now. Donna will be able to comment on that. And Lori or Sophie, one of them spoke this morning about Bill 14, about change the Long-Term Care Act to deal with dementia and accommodation of religious and spiritual needs. So I think all of this speaks to the changing demographic of who is in these homes. Don, maybe you can give us a little bit of background about that. And then Lorna, from your own experience, you might have just seen the level of care required in these homes now. And then Farah, you'll pick up something interesting in this. So Donna, why don't you start?
Yeah, the average age is 82.
Oh, Amy.
So we're certainly, that is an increase, though we to one of my earlier points, we are seeing a younger demographic coming in, especially in and around the psychiatric hospital communities. So around around Ontario Shores in Toronto, we have some homes where it's largely mini CAMHs, which especially in and around Parkdale and close to CAMH. So we're starting to see some differentiation happening in the populations. We do have younger people with early onset Alzheimer's or Parkinson's, where you're getting it, which is starting. Again, it's the family members. So Lisa Raid has become a big advocate for more specialized long-term care for younger populations. So whether it's an acquired brain injury or some form of dementia, because it's a different experience for a young family to come in where you do have an older population. So I do think that right now we are at a cusp where there's such an opportunity to either, for instance, in Toronto, have designated floors or neighborhoods that are more dedicated to specialized populations, so that you're thinking about what the family experience is more sensitively, and be more responsive. One of the challenges with a mental health population in long-term care, our homes have a duty to protect under the law. And we have a duty to protect anyone who's admitted and living in a long-term care home. So whether that's an individual who's coming in with a mental illness and may have behaviors, lifespan psychosis, who may need more restraints, different kind of medication management, but also everyone else who lives in a long-term care home. We cannot decline an admission. So just as the families are now not being able to actually really have choice, a home can't deny an admission. And so we are seeing an increase in inappropriate admissions, where it is somebody who should likely be in a psychiatric facility getting more specialized supports. So our homes are not built to think about ligature risks, to think about how furniture might be weaponized. We are not, our staff are not trained to deal with a population where somebody may have psychosis with maybe an overlay of dementia, which changes those behaviors. Our homes are incented, and the goals are to take people off antipsychotics. We don't use restraints. And what we're finding now is that the police don't even want to come into a long-term care home. So our home is going to be charged if there's a critical incident involving somebody with a mental illness where they may have harmed another resident. We have failed both residents, even though we may have would have preferred not to admit someone. And so we are starting to see some really disturbing trends where even there was an incident about a year ago where a resident, the home called a psychiatrist, and they wanted to form someone. And of course, like everything in the mental health sector, the police come, not an ambulance, the police come. And so when the police arrived, the gentleman in question assaulted the police officer and was actually arrested and ended up in the detention center and was actually murdered by another inmate. And it was very complicated because the public trustee was involved, the guardian and trustee was involved, but we need to do better in thinking about more diversified and more specialized types of long-term care. One of the challenges the government will be having as well, because again, it's about community. The government is running some pilots right now where we can prioritize admissions into cultural or linguistic or faith-based homes. However, the hospitals still get to control placement. So it's only when there are spaces available. So again, I think we're going to see families pushing back, where we know that because we know that people with dementia actually will default to their mother tongue. So whether you're from the Italian community or the Jewish community or a Muslim community or a Francophone community, we're starting to really see some real tension where families want admissions into their cultural home. There are tensions there as well because the cultural homes are largely nonprofit and they're trying to fundraise for their community. So if you can't control the census in your long-term care home for your community, then what's the incentive to actually donate to support that home? So there are a lot of unintended consequences. We're building a new long-term care home. One of our member homes is the Magellan, where the president of Portugal actually came for the groundbreaking for the Magellan. La Una is a huge sponsor. So we have a lot of workers from the Portuguese community who are actually building this new long-term care home at Bloor and Dovercourt. I think that this is what I'm watching because I think they're going to be hard pressed when they find out that they don't actually control admissions into that long-term care home. So we are starting to see those tensions. Baycrest has challenges. They need to keep kosher, but if their census is below 60% of Jewish people, that impacts their ability to be observant in terms of the respecting the religious requirements for a kosher home. And it's more expensive to run and operate a kosher home. We have individuals in Yihong who don't speak Cantonese or Mandarin, don't like Chinese food. We're starting to see this breakdown. So stay tuned. Again, as people age, I think some of these cultural and community expectations are going to be create some new challenges in this respect.
Lauren, did you see anything like that in Schlegel home?
I did see on our floor of 20, there were 3 people who were under the age of 50. And so our management has told family council they have been mandated that they should be prepared to accept people between 18 and end of life, like aged. So it's becoming a bit of a dumping ground in like difficult younger cases. They'll put them in long-term care.
Yeah.
And yeah, that whole idea of not having choice is just not flying well with my demographic. Yeah, I've just, what do you mean? And I can't imagine what those dear Portuguese people are going to do with all that passion. I mean, they get the president in Portugal. It's, people do expect choice in healthcare, and aging is a healthcare issue.
Laura?
Yeah, so I think you've really identified a critical issue, and I don't have the solution for long-term care. But I think what we are doing at SC is first the training of our healthcare providers to be able to deal with the dementia care, with strong palliative care ties. We also have hospice, so we're not just dealing with a demographic. These are hospices for homeless. And so that's a very unique model because everybody deserves to die with dignity. So there is a whole population that, never gets addressed as meaningfully. I think in terms of our home care and what we are providing is again, that real strength around palliative care. So if this is a palliative situation, it is that constant support and the ability to die comfortably, which we've done for decades. The other piece is, again, dementia care and partnerships we're working to build around that mental health and at-home care. So trying to address that need because, as you mentioned, it's becoming more prevalent or we're more attuned to it. And, just from the cultural perspective, one of the things, we have such a broad diversity of cultures at SC Health. We provide a ton of care, very, very multicultural, and definitely have done, prior to probably any other organization, we have real deep Indigenous partnerships and roots. And so we have really addressed the ability to provide culturally sensitive care. And so that's something that is, again, all of our care providers are trained. All of us, I think, as supports for the system are trained to deliver that care. So, you know, trying to mitigate some of these concerns as best as possible, but probably not fast enough, if I'm going to be honest. Yeah.
Well, there's a lot to be done, we can tell, but so many good things also in progress. So it is inspiring and encouraging, while at the same time, we all have to take a deep breath as we wait for that silver tsunami to really hit in 2027 with the doubling of the population over the age of 80. I want to thank our panelists very much for joining us today, and thank all of you for attending. As I said earlier, you will be getting a survey. We'd really appreciate your input on that, and the materials will also be available and will be sent to you. So thank you so much, our panelists and everyone. And lunch will now be served for those in attendance. Those online, we hope you have a nice lunch where you are as well. Thank you.